then I'm going to podcast. I've only got about 10 questions left on the test to make, and then I got to figure out. I've written a lot of questions. I got to figure out which ones I'm going to actually use. Then I'm going to make your podcast tonight because I just want to get it done. I've got clinical the next 2 days. So I'm going to do, I think this will work out cool. I'm going to make a review sheet for you like I did last time. And then I'm going to pull the sheet up and then do a podcast and talk through each of the categories and give you any information that you might need to review. So I think it'll work out kind of cool.
Aren't you generous?
Well, I had to pay for that stupid Screencast-O-Matic, so I'm going to use it.
Do my hospital paperwork too.
It's all interactive. That makes my classes like interactive. Which it's supposed to do.
Oh, don't they look sweet?
Okay.
Yeah, I had one about
Okay, so bipolar disorder. So, knowing what you know about bipolar disorder, what your preconceived notions are, why is bipolar disorder kind of unique, but kind of cool within the psychiatric mental health community? What do you guys think it encompasses that makes it a little unique?
the extreme highs or extreme lows.
You go from extreme highs to extreme lows. But if you look at the definition of bipolar disorder, you go from major depression, so it encompasses major depressive disorder. You've got mania in there, but just like we talked about stimulant psychosis when you're extremely high, when you've got the mania, you can also develop symptoms of psychosis. So you've got the hallucinations and the delusions. So therefore, you've got some schizophrenic type symptoms that are in there. And then you've got your just extreme mania that goes into it. And then, so when you take a step back and look at it, you've got all these different symptoms of varied mental health disorders that are thrown into one diagnosis. So it makes it a very unique disorder to deal with because you've got so many types of signs and symptoms that come into play. Now we did talk about this in major depression because I know that we covered it with you guys, but mood and affect come into play here. So mood is the inward feeling, and so the inward expression that we associate with is the individual. So that influence inwardly about how we either feel depressed, joy, elation, anger, anxiety, and if we remember all the way back to anger and aggression, if we have unmanaged anger, that can lead to violence. And then aggression comes after that, where you're having aggression that stems from that. Affect, though, it's very useful with assessment, the assessment characteristic or aspect of it, because it's the outward experience, or the observable experience of the emotional reaction. So we can see that. So we can describe someone's affect as the nurse. So with mania, what we want to be keenly aware of is that it's an alteration of mood where people are extremely, extremely up. So they have these feelings of elation, inflated self-esteem, grandiosity. If you listen to the schizophrenia PowerPoint, that podcast, there's delusions of grandeur. There's a whole slide about different types of delusions. And so definitely take note of that. So an individual, when they're manic, will have these delusions that will come into play. I could or might have, possibly, maybe, kind of sure, might have done. Just wrote a question that maybe had nothing to do with it. Like I've been in my office all day writing test questions, and it might have been one. Hyperactivity, agitation, racing thoughts, accelerated speech. So when you talk about mania, Jesus Christ, stop coughing. So when you talk about mania, true mania, it's very characteristic. It's not just being up and being someone like you think about an individual on stimulants being hyper. They're awake for days on end, maybe over a week. They're bouncing all over the place, and it takes several people to control and contain these individuals. They have very eccentric type behaviors. They're spending their entire life savings. They could be sexually promiscuous. They could just be running around naked. Their behaviors are very, very odd and very out of the ordinary. Mania can also be triggered by medical conditions. It can also be triggered by substances. We've already talked about substance-induced psychosis. And so, with the historical perspectives, you don't need to know anything specific about the historical perspectives. I always leave them in and include them because of just the food for thought aspect. So with the epidemiologic perspectives that come into play, what's interesting about this disorder is it's relatively equal among men and women. It's more common in single people, and kind of bless you, a little bit different is that it's more common in higher socioeconomic classes. And a lot of the disorders we've talked about, it's more common in lower socioeconomic classes. And depression is ranked what? Do you guys remember? Depression was ranked first. It's the leading cause of disability, and it's ranked first in mental disorders, and this is sixth. But if you remember, major depression is part of bipolar disorder. So when you're looking, if you go back and you look at the first few slides of your depression lecture, and then you look at this, major depression, in order to meet the diagnosis of major depression disorder, mania, they make sure to exclude mania. There's no history of mania or instance of mania, and no substance abuse history. So those two things have to be absent in order for a major, and there's length of time. But those things have to be absent in order for a major depression diagnosis to stick. With bipolar, you have to have these mood swings, and you have to have a history of major depression that comes into play as well. So again, interestingly, delusions and hallucinations can come into play. And so you've got our major depressive lecture, schizophrenia. You've got bipolar disorder, so really pay attention when you're reading the questions to the scenario or the stem of the question, and read it closely and read all of it, because don't just hone in the first sentence, oh, psychosis, there's psychotic hallucinations, okay, it's talking about schizophrenia. Because you might get through it, and then it might be some euphoria, hyperactivities, whatever. It might be talking about something different, so make sure to pay attention to all the details in the stem of the question. So you think about it, like I've told the other classes, you think about taking care of this patient and get a clinical snapshot of what you're dealing with. I mean, really think about this first bullet point. So you've got somebody that goes from major depression, so we talked about dealing with that. I mean, so depressed and sad, you're talking about someone that wants to kill themselves, like fetal position, can't function in society, they can't, no ADLs, anything like that, to normalcy. What? I'm fine. To mania, staying up all day, like Lucille Ball and Greg's Chocolate Factory type of thing, like all over the place. Back to wanting to kill themselves, back to being normal. It's Sybil, who the hell am I going to wake up to today? I mean, that in itself would make you want to go crazy. I mean, you're ping-ponging all the way around, dealing with all the, and they're talking to people that aren't there, they're seeing things that aren't there, they're misinterpreting things that aren't there. That's an intense diagnosis to take care of. Yeah.
I was just wondering, does it change really quickly, or do they stay depressed for so long and then it changes?
It can be rapid cyclical changing. It can take a long time. It depends on the person. And then with medications getting thrown into it, like I was talking to a colleague of mine the other day. She's a family nurse practitioner. She has her doctorate. She's thinking about, she wanted to talk to me about several things. She's thinking about going back and getting her psychiatric nurse practitioner, but she has family that struggle with this. She took them into Norton's. People in here are with me at Norton's Clinical. And then, no, this is, oh well, never mind. But I have people that are immune with Norton's Clinical. And they gave them lithium. They gave them high doses of lithium. And the problem with Norton is they have a lot of med school residents that are there, so they're just like dabbling in psychiatry. And you know, if you're a med school resident, they're probably some of the most haughty people I've ever met. Like, they won't speak to us. I mean, they're the ones who didn't know what a safety plan was. Ask us, we don't. But they start prescribing all this stuff, and they don't really take things into consideration. So they gave him a bunch of lithium, and it bottomed him out. Like, it boom, it threw him out of mania. They jerked him off his Vyvanse. Some idiot was giving him Vyvanse, you know, a family doctor or primary care provider who didn't know what bipolar disorder was. So they're pumping him full of Vyvanse, which, if you have bipolar disorder and you're in mania, that's the perfect thing to do, is give him a bunch of freaking stimulants. So he was up. So they jerked him off his Vyvanse. That threw him into withdrawal. Then they gave him a bunch of lithium. That bottomed him out. So then he went into the depressive phase of bipolar disorder. They kept him for like 3 days and then kicked him out with no follow-up care. So he was like wanting to die because he felt horrible. But they gave him no type of SSRI or SNRI or anything to stabilize his behavior. So he just felt depressed. There was nothing to help stabilize his mood. He was on no mood stabilizer, no antipsychotic or anything. So of course, what did he want to do? He wanted to kill himself. Well, that wasn't necessarily because of the disorder. That was because of the medications we were giving him. So you got to be very careful about meds as well, because that can play a huge role. So the onset and continuation of these symptoms can follow a seasonal pattern. That's with some patients, not necessarily all of them. Again, with the clinical picture, pay attention to how the mania is described, because it might be hypomania. And hypomania is different because they're still able to perform activities of daily living. They're still able to function. They're still operational in society. That's different than your mania because they are not able to function. These people are still cognitively aware. They're actually cheerful. They're pleasant to be around. They can become irritated when you try and redirect them or if they're told no. With true mania, that's not the case. Their thoughts very fragmented, or they're incohesive, like you can't talk to them or anything. But hypomania is actually pleasurable for a lot of people with bipolar. So something you definitely want to add to this slide and take note of is with the mania and with true bipolar, your bipolar 1 and 2 diagnoses and stuff. In order for bipolar to be diagnosed, you have to have a history of 1 or more manic episodes. And that can include the acute episode that's occurring right now. So you have to have a manic episode, a history of at least one that can include the one that the patient is experiencing at this current time. So it's not like you come into the ED and you've got a patient that's manic and severely impaired, acting all over the place, and the doctors can look at them and say, that's interesting. Go on home, and when this happens again, swing on back around, and then we'll take care of them. They'll be like, oh, no. Bring them on in. We'll take care of that. So it can include the episode that they're currently in.
So could that be the initial onset, or they've had a history of at least 1 plus this?
No, it's the initial onset.
Okay.
So they'll include that as, the history was a few hours ago. Okay, that's enough. So they'll take that as well. So your bipolar 1 and bipolar 2. This is easy to differentiate because at first glance people are like, well, how many are there and what does that mean? But it's like coming in first or second place in a competition you don't want to win. So, easy way to think about it. So this client is experiencing the major depression disorders, the major depressive symptoms that we learned about yesterday. And plus they have a full manic episode. So it's like, yay, we're having full mania, first place. So they have full mania, and they have major depression. That's bipolar 1. And with bipolar 1, they have hallucinations, delusions, and they can actually go into catatonia, so a catatonic state, where they'll actually get into a trance. You won't be able to break their expression. They'll stare off into space. And if you've if you've watched the podcast for schizophrenia, there's a lot of definitions in the schizophrenic lecture, and I talked about them, but there's a lot of overlap and they're very confusing. You don't see them a lot in clinical documentation because they're even confusing for the providers. Flight of ideas, loose association, overlap. How do you discern what they are? But one thing you do have to differentiate between is hallucinations and delusions. So, does anyone know what the difference is between the two? Want to take a guess at it? Yeah.
Hallucinations are something you see or hear, and a delusion is something you think.
Kind of close, not quite. So, you can have like hallucinations in your mind and stuff. The big thing is with people outside, we can't validate the hallucinations. Hallucinations the patient's having, and those you can like have gustatory hallucinations. You can have command hallucinations that are in your head. There's all sorts of different types of hallucinations, and they're listed in your PowerPoint lecture. But the delusion, it's something in the external environment that you're misinterpreting. And so like this is an easy example. Like, is this a drone or is it a ceiling fan? This little janky ceiling fan that Kentucky One makes, because they're going out of business. So, you're like, no, it's a ceiling fan. No, it's a drone or everyone's spying on me. No, it's a ceiling fan. So they're misinterpreting external environment. And you can't convince them otherwise. So they're having a delusion. They've got delusional behavior. And then hallucinations were like what we had on the last test. I hear voices that are talking to me. Okay, well, I don't hear those voices. Well, they're telling me to do something. Well, what are they saying to you? We can't hear any of the voices. Now, when it's severe, they're not going to understand that we can't hear them. They think we do. Now, if the patient's developed good cognition and come out of their psychosis, they're going to understand that, okay, I'm having voices in my head. I know they're not real. I know you can't hear them. Okay, well, you don't want medication to fix it? No. I like my voices. I'm used to them. I've had them my whole life. I know they're not real. I know what they're saying isn't valid, but it's fine. I just want to let you know I'm having them. So you can document it or whatever. I'm going to go back to my room. Okay, that's fine. Whatever. If that's somebody who knows is really attached with in tune with their diagnosis. But knowing the difference between the two is important. Yeah.
So once somebody is able to recognize that they have that, will they always be able to, or can they still revert back?
They can revert back. That's someone who's probably really medication compliant, has severe, like schizophrenia, severe psychosis, but is under control. There's probably PRN medications that can mitigate their voices and make them real insignificant. Some individuals, because they've operated with them for so long, and some people still believe that it gives them special insight, and they like to hear them because they're so used to it. And so they don't want them to completely go away. So that just happened at Central State with a patient. And I was like, well, I can give you some PRNs. They had PRN, Seroquel and Ativan and like Benadryl. And I was like, I can give you a bunch of PRNs if you want, so you can go. No, I just want to let you know that I was hearing stuff. That's another. Personally, I wouldn't want to hear things, but whatever. So that's important to take note of. So with bipolar 2, you still have major depression, but you have hypomania. So with the question, and this is where I think people got in trouble on the first test, is it gonna be as cut and dry as patient comes in presenting to the ED or to the psychiatric unit, and they have full-blown mania with major depression? What is Professor Ryan talking about? A, B, C, D. Okay, well, it's not gonna be that simple. There's gonna be a scenario that's gonna describe how heightened they are. They've been up for a week. Da 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 da. You know, the nurse thinks that they have this diagnosis, or here's the symptoms they present with, or you know, they're cheerful and pleasant and have been getting 3 hours of sleep per night. Okay, well that's more of hypomania. So being able to assess and analyze the situation.
I was a little bit confused about that, so I asked our, clinical instructor, he thought that like if you were up less than 4 days, it was like hypo, and anything over 4 days would be
Who's your clinical
considered.
instructor?
Chris Florio.
Okay, not listening.
I was just, thinking, oh, is it that easy to determine whether you're hypo or not, how long you're awake?
No, hypomania
Or
is
sleep.
not if you're up less than 4 days. No. Okay. Listen to your professor instead. So, but you've never met a full manic episode. And we'll go over this signs and symptoms of hypomania that are listed in here. This is nothing about staying up for more than 4 days. So cyclothymia, what's this remind you of that we talked about in your depression disorder?
Dysthymia.
Dysthymia. So there, make a little correlation. So it's got that same 2 years. There could be something about cyclothymia or dysthymia on the test. Consider it. So you might want to take note of that. So you're having numerous episodes of hypomania and depression, but they're not significant enough to meet bipolar 1 or bipolar 2 diagnoses. So it's not a significant enough diagnosis to meet those. So substance-induced, I like that typing. She is typing with such ferocity up here. She is typing like she means it. I like that note-taking. It's good. Do it like you mean it. So substance-induced makes me just proud. Substance-induced bipolar disorder. It's not bothering me at all. It's just,
Quiet.
no, it's fine. I was like, she is taking them notes. Good. So.
Don't you see my pen smoking over here?
She's right up the storm. Sorry, equal opportunity. Off again. So, with substance-induced depression and bipolar disorder, the important thing that you want to take note of. Okay. Yeah, the important thing you want to take note of is that this normally is going to happen whenever you're experiencing withdrawal. And with your being attached to another medical condition, what's the first one that comes to mind? Think more on your child and adolescent spectrum. Because with most medical conditions, you're going to become very sad. But what's, like your, say, cancer, HIV diagnosis, something like that. But which one would you be able to tie the mania with?
ADHD.
Excellent, your ADHD diagnosis. So that's very difficult to balance an ADHD diagnosis with a bipolar diagnosis because you've got stimulants that are involved. So it's difficult for healthcare providers because at OLAP we have healthcare. We have patients that are as young as like 9, 10, 11. They're getting bipolar diagnoses. They also have ADHD comorbidity. So how do you balance that and still treat ADHD, treat bipolar, not send them to a manic state, but have to give them medications to treat both? So that's difficult. So they'll try using off-label medications, Wellbutrin, that kind of thing. I'm not going to ask you that, but to be able to treat the ADHD and then give them antipsychotics to try and treat the bipolar disorder or anticonvulsants. So, a suicidal client with a history of manic behavior is admitted to the emergency department. They document the diagnosis as bipolar 1, current episode depressed. And so you'll get questions on the test like this too. It'll say current episode depressed. So that's just describing what phase they're in, either mania or depression. What is the rationale for this diagnosis instead of a diagnosis of major depressive disorder? B, they've had an experienced manic episode in the past. So with excuse me, with the predisposing factors, I haven't written a question about this yet because it's very difficult to formulate this into a question, but it's very interesting and shows a lot about the research we've done on this disorder and psychiatric mental health. There's obviously a predisposition, a familial and hereditary factor that comes into play here. Because if you have a family member, especially a close, like first or second generation family member that has bipolar disorder, they found that you're 2 or 3 times as likely to have bipolar diagnosis. And they've actually separated identical twins, monozygotic twins at birth, and had them raised by other people that have been raised by other people. So it takes the nurture versus nature thing out of there. And they've been up to 80% correlation with bipolar diagnosis. So we know that the biochemical influences are pretty the same with all of our psychiatric illnesses, with its norepinephrine and dopamine. I had a good question in the last class about using stimulants to treat depression and how that plays a role. You have to remember with your ADHD medications and stimulants, what are they directly impacting? They're having a direct effect on your central nervous system, whereas your SSRIs, your SNRIs, your antipsychotics, they're affecting the reuptake of biochemicals in the brain, whereas your stimulants directly impact the central nervous system and, cellular activity on that level in the synapse. And so you're not messing with chemicals, you're actually impacting the way the central nervous system is working. And that's why they have such a addictive impact, and you build tolerance to them and you want more of them because what? So when you're looking at childhood and adolescence, we talked about the ADHD impact, but lithium's a big one. There are going to be questions on the exam about lithium, so just take note of that. You're going to need to know your lithium levels, so I'm going to put that out in the podcast. So revisit it and know your lithium levels. You're not going to have to write them, but they're definitely going to come up in questions. Depakote's on there. That's Valproex, but Depakote, it's an anticonvulsant, so you'll need to know that. So lithium and Depakote, it's not just limited to child and adolescent individuals. You can use adults, treat adults with it as well. Other medications you'll need to know in this atypical antipsychotic class is Seroquel, and Zyprexa, Zyprexa-Zydis. And the Zyprexa-Zydis is just a disintegrating form of the medication. So for those in the back, Seroquel is S-E-R-O-Q-E-L. S-E-R-O-Q-E-L. And Zyprexa, Z-Y-P-R-E-X-A. And then the Zydis is Z-Y-D-I-S. And that's one medication, Zyprexa-Zydis. Or you can give Zyprexa by itself in a tablet form. And it actually comes in IM as well. But the Zydis is a dissolvable tablet. You can use it with, you put it sublingually under the tongue, and so we know absorption is much better with that. So it works for adults too. It's used commonly in children, but it's really good in adults too that cheat their medications, and it acts really fast, so you can give a high dose in adults and it works really well. So we talked about the ADHD. You have to be careful when using those in the treatment because it can exacerbate bipolar symptoms. Make sure I'm not missing anything. Let me tell you. All right, so we know that we want to, whenever we're looking at treatment strategies, especially with children, but this can go with anybody, we want to use psychoeducation, psychopharmacologic treatments, as well as therapy. So we always want that multi-pronged treatment whenever you're looking at psychiatric illness. And that's really easy to discern when you're answering a question. So just thoroughly analyze the question and make sure you're utilizing the best selection that involves the most treatment options available. Now you are going to need to know the stages. I'm not going to make you write them out or anything, but these will be helpful in selecting the best answer for questions that talk about bipolar. So with your stage 1 hypomania, so it's not as severe as your acute manic stage or your delusional phase. So they're cheerful, individuals are cheerful and expansive in their thought. They do have underlying irritability if their wishes or desires go unfulfilled. They have a lot of self-worth. Like it says up here, they have rapid flows of ideas, so cognitively, they're very heightened. They laugh and talk a great deal. They're productive because they have an increased motor activity. They're able to get a lot done. When you look at your stage 2 with your acute mania, so they're very elated, euphoric. They seem to be on this continuous high. So they have racing thoughts and overconnection of ideas. Very pressured speech. This is where hallucinations and delusions come into play. They have a lot of sexual inhibition. They have little need for sleep. Their cognition is very fragmented, so they don't make a lot of sense. Have you ever been in, sometimes you'll be in the clinical setting, I don't know if anybody's ever heard this about like bipolar makeup or anything, like people like have clown type makeup on or they'll wear like a lot of jewelry and stuff like that. You'll see that if you work in psych, you'll see patients coming out and they'll like draw on eyebrows and have on like lots of lipstick and stuff. Or you might have nurse managers or nurses that you work with that come in and will be like, whoa. But we had one nurse manager that we always said was bipolar because she had bipolar makeup. So when you look at stage 3, your delirious mania, so they're basically so worked up that they have this sense of panic. So they're making no sense. They're disorganized. They're almost impossible to control. I mean, it takes several people to contain them. They're very frenzied. I mean, and to give you an idea of how serious a full manic episode is, I mean, they're so active that they can actually exhaust themselves to the point of death. That puts it in perspective when you think about how active an individual is. I mean, so they're a difficult individual to control. You're like, sit down, stop moving. Like you can throw so many drugs. There'll be a little peanut of a woman, like tiny, bitty, and she's going so. I mean, you'll throw like 10 milligrams of Haldol, 2 milligrams of Ativan, 50 milligrams of Benadryl, 50 more milligrams of Benadryl, 20 milligrams of Geodon. I mean, you'll just be like, wing, wham, boom, bam, and they're just like they don't, and nothing phases these people. And you're like, where's the bat? Where's the bat? It's time to get the bat. Like, because no medication, you can't bring them down. You're like, I need the tranquilizer gun. That big gun that brought down the T-Rex, you know? Because you just can't stop them. They don't sleep. I mean, it takes them several days to like, of just throwing medications at them. We had a little, and everything stays in this room because it's like a little HIPAA-ish, but we had a
Just saying it's
like HIPAA was breaking stuff. But we had a little Asian boy named Suk, and he was insane. He was like a cute little guy. He was from Thailand, but he was crazy agile. Like he was in mania for a good couple weeks when we had him. We actually had a med audit, and we'd given him like 4 times the recommended dose of Cyprexa, like in a day, like in a 24-hour period. So we got in trouble for that because no one thought to actually count the number of INs we were giving him, and we just like saturated. His little body was just squeezing out like Cyprexa INs and IN Cyprexa. We gave him so many meds, and nothing would help. He would take his clothes off and make big turbans out of them and put them on his head, and then do like, I don't know how he figured it out, but he would do like tumbling down the hallway. He was like a gymnast. He would be like, and he would make little sounds when he was doing it. And you were like, what the hell is this kid doing? He was like, we tried to put him in a hold once, and then we just stopped putting him in holds. We just let him get it out of his system. Tried to put him in like an upper torso, like a big dude did. And he was so tiny. I mean, he was like my size, like little bitty tiny, but like skinnier than me. He was like, and he like flipped over the person, like walked up a wall, like it was the Matrix. Like it was like, like behind the person. It was freaky. The only way that we calmed him down at night, because he was such an annoyance at night, was I'd never seen Game of Thrones before, and the nurse I was working with was like a big Game of Thrones person. So she was like, oh God, you've never seen Game of Thrones? Savage, it's crazy. And like 5 seasons had gone by. So she pulled it up on her HBO Go on the computer. Don't do this in the hospital, by the way. Like, this is so bad. And so I'm watching it. You know, Game of Thrones is kind of racy. Like they're showing like stuff you're like, ooh, you're not supposed to watch. And so I'm watching it, and I'm like sitting back with my feet up in the chair. This is how psych is at night, by the way, if you ever want to have a nice job. So I'm watching Game of Thrones, and then I turned around, there's Sook at the nurse's station door. And I was like, and normally we're dealing with Sook all night long. So there's Sook at the nurse's station door. And I'm like, Sook? You know, lady was like, okay. I was like, you like this? And he was like, yeah. I was like, okay, so this is good. I was like, if you promise not to karate kick anybody anymore tonight, Sook, I'll let you watch Game of Thrones with me. And he was like, okay. And I was like, so you're just gonna stand up here and watch TV? He was like, mm-hmm. It's like, you want me to open the nurse's station door and get a chair? He was like, okay. And I was like, no bad behavior. So I got him some little snacks. And then it gets done with the first episode, we get into the second episode, and he's still sitting there eating snacks, and I was like, can we put some clothes on? And he's like, so we got him dressed, and more episodes goes, and I'm like, you like this? He's like, we can do this every night, but you gotta behave yourself. You gotta be good all day, and we'll watch TV at night. So every night we're watching episodes of Game of Thrones. It worked, like, wonderful. So if he was bad, we wouldn't watch any Game of Thrones episodes of his mom. But if he was good, we got to watch Game of Thrones. We made it to like season 4. I mean, it worked wonders. Therapeutic relationship with your patient right there. Every night he was waiting when I walked in, and he was like, it was awesome. So that's a way to get a patient mania right there. So I can see y'all in the hospital. Do you have a computer that you can pull up HBO on? They'll be like, what? And you'll be like, I learned from my nursing professor. So, you wanna do a good assessment to find out things about your patient, like if they like Game of Thrones, or other important information, and that's in that pre-intervention and, introductory stage. Like we learned about for the first exam, that's not coming back to bite you yet, it will be on your final. But so when you're measuring outcomes, this is pretty common sense. Make sure to really read the question because this is so similar to your suicidal ideation lecture, anger and aggression lecture, depression, it's coming back again. I mean, all of these overlap, these outcomes do. So no physical injury, hasn't harmed anybody. Some kind of a standalone that comes out is your nutritional intervention that's in here, your nutrition outcome, because these patients lose weight. Accepting responsibility for their behaviors, that's a big one, because if they were in active mania, heightened sense of mania, then they're gonna be doing things that probably disadvantage a lot of their family and friends. We want them to get into a normal sleep cycle. So the initial stages of caring for a client experiencing an acute manic episode, what should the nurse consider to be the priority nursing diagnosis? What do you guys think? So all these are pretty good, but what's the best? Personal safety. And like I said, I'm not gonna ask you anything about like developing a specific nursing diagnosis. But there are questions where a nursing diagnosis is included in the STEM and you have to pick appropriate interventions. So these are good for examples. And these help you kind of discern what proper selections are on the exam. So just kind of give these a little honorable mention. But if there's a risk for violence, maintain a calm attitude, remove dangerous objects. Restraint should be the last intervention that you use. Setting limits, not arguing, positive reinforcement. Sleep is big for your bipolar patients. Caloric intake. Concept care mapping can go, I mean, it's a good teaching tool. It can help with education. This is where nurses, where we develop roles that have all those different roles. We can be a patient teacher. And then assessing is the final step of the nursing process. One thing I wanted to point out is with anything, before you call a provider, what do you need to do if there's been an odd assessment value? And then you're gonna call a provider, but that first assessment happened an hour or 2 hours ago, you want to do what? Reassess, because this came out to me because I was at house a few times since our last exam at Central State. And nurses, or even seasoned nurses, they constantly wanna call the doctor over something real stupid, and then they haven't reassessed the patient or even initially assessed the patient properly. And if I was a provider, what's the first thing I'm gonna ask? Well, do you have like vital signs? And then there's nothing wrong, these are crazy people, you know, they have a mental illness, and what they're commenting on doesn't make sense, and you haven't even like done basic things, so it's kind of nursing 101. So, in a manic episode, you guys just picked the right answer, that personal injury. Have they been violent? Has their agitation got under control? So, anger going into aggression and being focused on that from our anger and aggression lecture. Nutritional status and hallucinations and delusions. We might not get them to cease, but like you were commenting on, how we got them under control, can they recognize them? So there's different ways that we can get hallucinations under control. Self-care, behavior that's socially acceptable, not taking off their clothes and putting them down hallways, getting themselves dressed, sleeping appropriate amounts of times. So taking their lithium, being able to understand early signs of toxicity. And so I'm going to include this in the podcast, but Early signs of toxicity are like tinnitus, blurred vision, slurred speech. So if you've got questions related to that you want to know. And so your different treatment disorders, of course, you want to have a combined therapeutic approach with psychopharmacology. Our recovery model, which they obviously didn't implement at Norton's with that story that I told you, is you do your inpatient treatment and then you develop good follow-up care utilizing the recovery model. So you teach that patient how they're going to live outside of the hospital and you carry that through to outpatient treatment. So the goal of the recovery model is to teach individuals how to lead a fulfilling life and a safe life and carry treatment out on through into society. You know, these are all the things that we're looking for to teach the patient and to have them do on their own. So of course you have to give a lot of support at the beginning. We don't have a lot of the resources we need to be able to implement this successfully. And with a lot of these mental illnesses, there isn't a cure. That includes bipolar disorder. But if we give enough support along the way, we can teach people how to successfully cope. We talked about ECT in the past, so this is when any type of medication regimen fails, and that includes lithium. ECT can be an option. You'll run into it so rarely in the psychiatric setting, and I'm not going to ask you anything specific, just knowing what it is good. So with your psychopharmacology, like I mentioned, know your lithium carbonate, know what the lithium toxicity is, and know your values. You're not going to have to list them out, but you're going to have to be able to apply them to multiple choice questions. Your anticonvulsants, your Depakote. Verapamil is a calcium channel blocker. Knowing that that treats bipolar disorder is good. You're not going to need to know anything more about it because verapamil, I've never seen it actually utilized for bipolar disorder. I feel it's an ineffective drug, so my personal preferences are coming into play here. I mean, the dosages are kind of wanky, and I haven't ever seen it really work. Antipsychotics, your Seroquel, your Zyprexa, your second generation antipsychotics are your good ones. Okay, second generation antipsychotics like Seroquel and Zyprexa, why are those preferred over your first generation antipsychotics like Haldol and Thorazine? Because they have lower risk of what? Yeah, your extrapyramidal symptoms. So with the depressive phase, so this kind of gives an example as to why we have to be so careful with stimulants, because even with antidepressants, that can trigger mania. So we have to be careful. If our SSRIs and our SNRIs can trigger mania, then we want to be very careful with our psychostimulants. This would be with our very sensitive bipolar patients, where mania is very common. So you guys know the risks of taking lithium, about the dietary sodium, monitoring for toxicity, anticonvulsants with Depakote are very like your Depakote anticonvulsant. The big thing is you have to titrate the drug up and down, monitor liver function tests. You don't have to know about your calcium channel blocker because the doses are so low. When I said the dosages are wanky, you're talking about like 80 milligrams, 120 milligrams of verapamil. I mean, and that's like what they give as a headache adjunct whenever you're talking about like migraines. I mean, it's a low dose. So, I mean, don't have to worry about that. I'm not going to ask you a question about it. Your antipsychotics, of course, don't continue any of your psych drugs abruptly. It takes time for them to work. It can cause orthostatic hypotension. And then just as a side, just know if the sun interacts with your medication. In other classes, I had students that taught in clinical, and I was on doxycycline for acne. obsessed with breaking out, so I'm always on my medication for my skin. Doxycycline interacts with sun. I knew that, but I didn't think it was like bad, because I tan well. So this summer I went out and I worked in the yard for like 4 hours. It was fine. But I was informed by a colleague of mine that was teaching clinical that I was geisha white. Like, she was from Japan, and she said, "You're like a geisha doll, you were white." And I didn't have that feeling that I was that pasty, but apparently I was. And so I went outside for 4 hours and I came in and I was like a little crab claw lobster. And my skin like was that color. I looked like that painting in the back. Like, my skin was messed up. My arms. Dr. Hawkins looked at me and was like, "What happened?" Like she thought I like got stuck in an oven or something. My face looked a hot mess. It hurt so bad. And I looked that way for like 2 months. Like it was that bad. I got oh, you remember, Blake remembers. Didn't I look a mess? I
remember it, but I've also had it happen to me too. So
yeah, I looked a hot
it's
mess.
the worst
It was
feeling.
horrible.
Yeah.
It was horrible. I was just like, and I would be in skills lab. I was teaching like 205 students, and so I'd be showing them stuff on the mannequin, and like everybody would get down and like point at stuff, and then my hands would come in, and I'd look like a frickin' like Krampus. And I'd be like, "Well, you gotta do, you gotta do that right there," because I didn't want to like put my hands in the picture because it was just hideous. All y'all's hands, all beautiful and glowing. Mine all withered and bad. So these are the symptoms that you want the individual to report. Obviously, any liver function issues come into play. So a client is being prescribed lithium and discharged on the medication. What should the nurse teach the client? Yeah, don't skip on sodium intake. So you want the patient to stay hydrated and eat enough sodium. Oh, we're done.
Dang it.